So we are here to discuss about the part 2 of the beta blockers lecture. So as you all know, in part 1 we discussed about some of the classification of beta blockers and what are its pharmacological properties pertaining to CDS, pertaining to its properties pertaining to catecholamines, its effect of beta blockers on the exercise. So we ended the part 1 of the lecture by discussing about the buffering effect of catecholamines during exercise and how beta blockers negate this effect. So now we'll move on to the pulmonary effects of beta blockers. So beta blockers pulmonary effect is best described by the use of non-selective beta blockers like propranolol. So propranolol, as you all know, have an affinity for beta 1 and beta 2 as well. So using propranolol in patients who are suffering from COPD or asthma, who already have a propensity of bronchoconstriction. So if you use a non-selective beta blockers in such patients, then definitely beta 2 receptors that are present on the bronchial smooth muscles are blocked. So as propranolol is a non-selective drug, it will not only block beta 1, it will also block beta 2. So blocking beta 2 in the bronchial smooth muscles will further aggravate bronchoconstriction in such patients of COPD and asthma. So such patients might suffer from life-threatening conditions that can be precipitated by bronchoconstrictions. Now coming to metabolic effects. So metabolic effects properties are mostly pertaining to the effect of beta blockers on decreasing glycogenolysis. So beta blockers usually decrease glycogenolysis. So glycogenolysis is the formation of or breakdown of glycogen stores that happens during for the response that happens to the response of hypoglycemia. So whenever a patient presents with hypoglycemic symptoms, so the body tries to correct the hypoglycemia. So for the correction of this hypoglycemia, glycogenolysis is essential. So but if the patient is on beta blockers, so beta blockers tend to decrease this body's response to hypoglycemia by decreasing glycogenolysis. So glycogenolysis is decreased by the use of beta blockers. Now again, hypoglycemia symptoms are blunted. So what does this mean? Hypoglycemia symptoms are blunted. So we have got symptoms of hypoglycemia like tremors, palpitations. So all such symptoms require the action of beta blockers on uh, specific sites. For example, during tremors, you need beta blockers to be beta receptors to be active on the muscle sites, and for the palpitations, you need beta 1 receptors on the heart. So in case a patient on suppose a diabetic patient who is taking anti-diabetic medications and he or she develops hypoglycemic episodes, so hypoglycemic symptoms like tremors and palpitations will be blocked if such patient is also taking beta blockers. So again, hypoglycemic symptoms are blunted. Now beta blockers stimulate HSL. So beta blockers stimulate HSL. HSL stands for hormone sensitive lipase. Hormone sensitive lipase. So hormone sensitive lipase is responsible for an increase of free fatty acids, for the release of free fatty acids in the blood. Right. So we will be shortly coming to how these receptors or the blocking of hormone sensitive lipase action can affect the metabolism. Right. So but beta receptors per se, they will stimulate the hormone sensitive lipase. Also we have got uh, actions of non-selective beta blockers on decreasing the HDL. So non-selective beta blockers have shown to decrease the HDL and to increase the LDL and triglyceride levels. So non-selective beta blockers, they tend to decrease HDL but increase LDL and triglyceride levels. But for a favorable lipid profile, we need to use drugs like celiprolol and nebivolol that tend to improve the lipid profile. So again, lipid profile improvement is seen by such drugs like celiprolol and nebivolol, but non-selective beta blockers do not have a very favorable lipid profile. So uh, using drugs like non-selective beta blockers and should be very cautious. Now coming to the adverse events. So adverse effects of these beta blockers. So as we discussed in the part 1 of this lecture also, that beta blockers most common adverse event will be bradycardia. So bradycardia, decrease in heart rate, and also these drugs are contraindicated in AV conduction defects. So we have discussed in the part 1 of this lecture that beta blockers tend to decrease the AV conduction or slow the AV conduction. They also increase the refractory period of AV node. So if a patient is suffering from AV conduction defects, then beta blockers are contraindicated in such conditions because they can aggravate that condition. And now coming to Raynaud syndrome. So Raynaud syndrome is a type of peripheral vascular disease where the small end arteries of the fingers are constricted, and you can see the pale signs. The fingers have become pale. The tip of the fingers on exposure to cold, they have become pale. In this diagram, as you can see, that the tip of the fingers have become pale on exposure to cold. So if the patient is suffering from any peripheral vascular disease like Raynaud syndrome, so even beta blockers can precipitate any of the peripheral vascular diseases. So again, the use of beta blockers should be avoided in such patients. So as we have already seen in the previous slide, that beta blockers can also cause life-threatening increase in airway resistance. So life-threatening increase in the patients who are suffering from COPD or asthma, who are already suffering from conditions like bronchoconstriction. So in such patients, the use of beta blockers can aggravate airway resistance, or they can aggravate bronchoconstriction in such patients. Insomnia and nightmares. So beta blockers will have a specific CNS effects of insomnia and nightmares. So the patients can also suffer from insomnia and nightmares. Blunting the recognition of hypoglycemia. So blunting the recognition of hypoglycemia. So the patients who are anti-diabetic patients who are taking some of the anti-diabetic medications are tend to encounter hypoglycemic episodes. So hypoglycemia is a very common adverse event of anti-diabetic medications. So if such hypoglycemia occurs, so recognition of that hypoglycemia is very important. So for recognition of that hypoglycemia, we have to recognize some specific symptoms of hypoglycemia, such as tremors, faster heart rate, sweating, confusion. So all such symptoms, if beta blockers are used in such kind of patients who are also taking anti-diabetic medications, and if such patient develops hypoglycemia, so the symptoms of these hypoglycemia won't be evident because the patient is also taking beta blockers. So beta blockers will block such symptoms. So such symptoms will be blunted. And also we have seen that the recovery from this hypoglycemia is delayed because beta blockers decrease glycogenolysis. So what is the precaution? So after seeing the adverse events, we come to the precaution section. Precaution, we have got beta blockers discontinuation should not be abrupt. So abrupt discontinuation of beta blockers after long-term treatment can exacerbate angina and may increase the risk of sudden death. So this happens because there is upregulation of beta receptors. So once the beta blockers are used for a longer duration, there will be upregulation of the beta receptors. So upregulation means there will be increase in the number of beta receptors, or there will be increase in the sensitivity of such receptors. So if you tend to stop these drugs abruptly, these beta receptors will show exaggerated response to intrinsic catecholamines. So if the patient is of angina or with some cardiovascular diseases, so again the beta blockers in such patients will show exaggerated response to the intrinsic catecholamines, and heart work will increase and oxygen demand will also increase. So what should be done? The tapering of the dose and restricting exercise during this period. So once you have planned to stop the beta blockers, stop it gradually. So the dose should be tapered slowly and then over the weeks, and then restricting exercise during this period, because as we all know that beta receptors have have upregulated, they have become more sensitive. So the patient should be told not to exercise, because exercise will increase the sympathetic activity and increase the catecholamines levels. So again, restricting exercise during this period is essential. So what is the precaution? So precaution is to taper the dose gradually, and tell the patient to not to exercise during this period. So what about overdose? So beta blocker overdose is also a case that can arise. So beta blocker overdose is usually presented by bradycardia, hypotension, prolonged AV conduction time, and widened QRS complexes. So bradycardia, as we have already discussed, that beta blockers are prone to cause bradycardia very often. And then we have got hypotension, prolonged AV conduction times, and widened QRS complexes. So to treat this overdose of beta blockers, to treat bradycardia, we can use atropine. To treat hypotension, we can use alpha agonists, right? So, but the first line drug for the treatment of overdose of beta blockers or beta blocker poisoning is glucagon. So glucagon is also a first line drug for the management of beta blocker poisoning. We can use atropine for correct specific conditions of bradycardia. We can use alpha agonist to correct hypotension, but glucagon is used. So what is glucagon doing? Glucagon is increasing the levels of cyclic AMP. As we all know that beta blockers block the beta receptors. So beta receptors were working. As we all know, beta receptors are the G protein coupled receptors. So they tend to increase the cyclic AMP levels, and this increase in cyclic AMP causes contraction of the myocytes, cardiac myocytes. So this increase in cyclic AMP was done by beta receptors, but now these beta receptors are blocked. So this increase in cyclic AMP can be achieved by an alternative pathway. So what is that alternative pathway? The alternative pathway is that of glucagon. So glucagon through an alternative pathway will activate or increase cyclic AMP, and in turn they will increase calcium and cause contractility. So it's just the way, it's just a means of finding another way of how we can increase the contraction of the cardiac muscles, right? Okay, so therapeutic uses of beta blockers. So therapeutic uses we will be discussing. So therapeutic uses may most common uses that we'll encounter of beta blockers is the cardiac uses. So cardiac uses, we have discussed that beta blockers have an antihypertensive property. Beta blockers can be used in angina because they decrease the oxygen demand. And we have got the use of beta blockers in acute coronary syndromes like ST elevation MI, non-ST elevation MI, right? And then we have got congestive heart failure because beta blockers tend to decrease the cardiac remodeling. Then we have seen that they can correct the cardiac rhythms as well. So they are used in supraventricular tachycardias because they decrease the AV conduction. And then they can be used in hypertrophic obstructive cardiomyopathy. So during hypertrophic obstructive cardiomyopathy, there is increase in the outflow tract obstruction. So beta blockers tend to relieve that outflow tract obstruction. So again, hypertrophic cardiomyopathy, beta blockers can be used. And also we have got the use of beta blockers in acute dissecting aortic aneurysms. Okay, apart from the cardiac uses, we have got the use of beta blockers in glaucoma. So we use beta blockers in chronic open angle glaucoma because beta blockers decrease the production of aqueous humor. So beta blockers will decrease the production of aqueous humor. So as we can see in this diagram that, so on this side, this is the open angle glaucoma. So in the open angle glaucoma, so first of all, what is the angle that we talk about in glaucoma? So that angle is between the cornea and the iris. So the angle is between the cornea and the iris. We talk about this angle. between the cornea and the iris. Okay, so this angle is open in the sense that this angle is open, and the aqueous humor that is produced from these ciliary bodies can now be drained through this angle. But the problem lies in the fact that in this angle we have got a structure present that is known as trabecular meshwork. So this trabecular meshwork is, the channels of this trabecular meshwork are blocked, right? Or there is underdevelopment of these channels, so that the aqueous humor that is produced through ciliary bodies is not able to drain out. So there is inability of the aqueous humor to drain out through these channels. So that's why we get increase in the intraocular pressures. So in this condition, if beta blockers are used, they will decrease the production of aqueous humor. Other uses, we have got hyperthyroidism. So hyperthyroidism signs and symptoms can be controlled by the use of beta blockers. So what propranolol does in this case is it inhibits the peripheral conversion of thyroxine to triiodothyronine, an effect that may be independent of beta blockade. So again, propranolol can be used in hyperthyroidism as well to control the signs and symptoms. So also for prophylaxis of migraine, so beta blockers are indicated for prophylaxis of migraine along with the calcium channel blockers. Then we have got acute panic symptoms. So during the panic attacks, there is an increase in the sympathetic activity, and the symptoms of sympathetic activity can be controlled by use of these beta blockers. So during the panic attacks, you will find these beta blockers to be very effective. Well, we have discussed most of the important aspects of beta blockers with respect to uh, most of the entrance exams, be it any postgraduate medical entrance exam. So we'll quickly have a review of all the pharmacological actions and therapeutic applications along with untoward effects. So for the review purpose, we'll focus on the class that is non-selective beta blockers, and we will quickly see and quickly review all the actions and uses along with adverse effects. So this class of non-selective beta blockers comprise of drugs like propranolol, pindolol, nadolol, timolol, right? So these kind of drugs are present in non-selective beta blockers. So we have already seen the pharmacological properties. What were the pharmacological properties? First was negative chronotropy, to decrease in the heart rate. Then we have got negative inotropy, decrease in the contractility. Then we have got decrease in the cardiac output as well. Then we have got decrease in AV conduction. We have got bronchoconstriction. So they were contraindicated in patients of asthma and COPD. So use of beta blockers should be very cautiously done in or use of beta blockers is contraindicated for that matter in the patients of asthma and COPD. So what are the contraindications for use of beta blockers in patients of asthma and COPD, and in patients who are having AV conduction defects? AV defects, because we cannot afford to slow down the AV conductions any further. Then we have got in patients of diabetes who are on anti-diabetic medications, so that if we use beta blockers in such patients, we cannot recognize hypoglycemia, right? So, and also in the patients of peripheral vascular disease, also in the patients of peripheral vascular diseases. So these are the contraindications of beta blockers, and in such patients. So please remember that these contraindications are very important, and these contraindications are tend to be asked in most of the exams. Then we have got a decrease in the free fatty acid levels. So decrease in the free fatty acid levels is achieved by, it is achieved by activation or the blockade of HSL. HSL was a hormone sensitive lipase. Then these beta blockers, as we have seen, decrease the HDL but increase the LDL levels. Again, we have seen most of the therapeutic applications like angina, hypertension, cardiac arrhythmias, congestive heart failure, pheochromocytoma, glaucoma, right? Prophylaxis of migraine, hypothyroidism, acute panic attacks, and also we have got one more therapeutic application, that is variceal bleeding in portal hypertension. So specifically for portal hypertension, if there is variceal bleeding, so beta blockers are indicated in such condition. We have discussed most of the untoward effects. Right? Fine. Now to end this lecture, we'll quickly see the antioxidant property. So antioxidant property of beta blockers. So this property has been identified with the use of carvedilol. So carvedilol possesses two distinct antioxidant properties. What it is a chemical antioxidant that can scavenge reactive oxygen species. So again, it is a scavenger of reactive oxygen species, and it can suppress the biosynthesis of reactive oxygen species and oxygen radicals. So again, carvedilol will lead to decrease in the reactive oxygen species. So reactive oxygen species. So reactive oxygen species is seen to reduce the myocardial contractility, stress-induced hypertrophy, apoptosis, and the accumulation of neutrophils in the myocytes, myocardial cells. So all these effects of reactive oxygen species, deleterious effect of reactive oxygen species on myocardium are reduced by the use of carvedilol. So this is an additional benefit or additional property of carvedilol to decrease the reactive oxygen species. So thank you so much. Any of the questions pertaining to this lecture of beta blockers, you can ask or just write it down in the comments, and please like, share and subscribe so that I can bring out more important lectures that will be helpful for your PG entrance exams. Thank you.